good to start kicking this off. Um, I'll be presenting today. My name is Amanda Randles. I'm a faculty in biomedical engineering here at Duke. And as a reminder before we get going, if you are physically here at Duke, we are having a coffee hour in the Wilkinson building in the lobby right after the seminar. So come, happy to talk about more of the research in depth, to talk about our center and talk about everything kind of going on. If you're available, please feel free to join. This seminar, as well as all the other seminars that we've had, will be posted onto YouTube. It's on the YouTube channel link. There's a computational health seminar playlist on Pratt's YouTube channel, and we also have it on our current website. And that brings us into, I wanted to kind of kick things off and start with sharing a little bit more about the center and kind of where we're going and kind of orient and anchor this of what we're doing. So we're launching this new Center for Computational and Digital Health Innovation here at Duke. We're really trying to kick this off later this semester, so kind of stay tuned for where we're going and what's coming up. We'll launch with the new website, show you some of the new activities and ideas that we have going forward. But I wanted to kind of start it. So the center is really where we are hosting the seminar series. We've kind of kicked things off with the seminar series as well as the coffee hours, and we're starting to broaden that out over the next semester. So we're really excited about where things are going and want to, kind of bring you guys in and see where we can get people more involved. So to give a little bit more information, the center itself is really focused on trying to address outstanding health issues using like key cutting edge technology. So our goal, if I can get, so our goal and our mission statement is really to help find ways to improve our ability to find, to track, and to treat human disease. And we're doing that through an array of different of options. We're using what we've initially defined as three driving technologies. So we're using wearable technology, extended reality, advanced computing, trying to bring each of these together to really advance the idea of our ability to create digital twins, virtual humans, understand more about the human body, and do so using these advanced computational tools. So you've kind of seen a sprinkling of this through the seminars. That's how we've been picking different people to start off and launch our seminar series. A lot of the seminar series to begin with focused on some of the faculty members that have, founding members of the center, kind of giving you a sense of their research. So you saw like Jessie Lynn Dunn with the wearable research recently. We had Maria Gorlatova in the beginning on the virtual reality side. We had Dan Buckland. So you kind of gave, it gives you a little bit of a sense of like where we're going and how we're kind of using these different technologies. And then what we're trying to do is bring it in, and we'll be starting more coursework. We're trying to launch a certificate program, and then we'll be launching these communities of practice in the next few months, kind of around each of these technology areas. We're going to get everyone together who's maybe, trying to code for the Vision Pro, get you all in the same room and try to, trade some tips and tricks of how do we actually improve that. We'll have opportunities for pilot funding within Duke, and there are other programs that are going to be rolled out slowly over the next coming months. We'll have the new website, as I mentioned, we'll be launching. We'll kind of share all of this through our mailing list and kind of putting it out there. So you'll see the QR codes at the beginning of the talk and at the end of the talk of how to join our mailing list if you're not on there already and you kind of found us maybe through social media. So please definitely join the mailing list and kind of stay abreast of like where we're going with this, what we're doing, and the different activities that'll be launching in the next few months. So with that, I'll jump into the research that we're doing in our lab and kind of like give you a sense of where the idea of find, track, and treat is, how that fits into our projects in the Randles lab itself, and a sense of how we're building out these digital twins, what we mean by digital twin, and how this is all coming together. So with that, I'll switch over into kind of talking more about what we're focused on in our lab, and kind of how this fits into the building of using high performance computing. We're now bringing in data from wearable sensors. We're trying to interact with the data in an intuitive way with the virtual reality side, enable, more intuitive treatment planning using virtual reality, to kind of give you a sense of a few different vignettes of different projects that we're working on, and kind of show you where we as the Randles lab are trying to envision how we envision digital twins and how we can make an impact. So for me, I'm particularly passionate about exploring what we can achieve using, the world's biggest supercomputers, innovative data types, AI modeling, accelerating the different breakthroughs. And I'm really excited about trying to merge our computational models and our physics-based simulations with the new advances in AI, along with this cutting-edge technology. So I'm, really excited about kind of bringing all of this together and seeing how we can make, a virtual human that will allow us to really shift from more reactive care of, the patient gets, has some chest pain, goes into the doctor's office, and they're going to react. We want to help the doctors be able to be a bit more proactive and shift to this idea of this proactive care. So in doing this, I'm going to give you a few examples of what we mean and how we're looking at it. So, as I mentioned, our goal is to shift from this reactive approach where the patient experiences symptoms like chest pain, weight gain, they might have trouble breathing, and that's something that's going to cause them to go to the hospital or go to a doctor's office. We want to shift from that to more of this proactive approach. That's really one of our driving goals. In this proactive model, we're not waiting for these critical symptoms to appear, but instead, we're going to continuously monitor the patient. We're going to do so remotely, and we're going to predict these health risks before they manifest in ways that may lead to these events or these crises. So you might be asking, how is this a little different than what we've conventionally talked about as preventive care? And so traditional preventive care really focuses on reducing your risk of disease over time. So, in the past, we've enacted things like screenings, vaccinations, lifestyle changes. Proactive care and how we're really envisioning this, on the other hand, is leveraging this continuous data to anticipate problems and address specific, individualized, personalized health events before they can escalate. So we're trying to catch these changes early and enable the doctor to go in and have timely interventions that can keep the patient healthier and keep them out of the hospital, and address things before that issue arises. So we're trying to move the point of identification up from when the symptoms occur to much earlier, where we have like maybe 10 days, 20 days, 30 days, a month before these symptoms might occur, and help us jump in and be able to make some kind of action and empower those doctors with this proactive information. And that's where we really see digital twins kind of coming in and playing a key role. So one example might be, we're working with the clinicians over in cardiology on heart failure, and we're trying to identify known metrics earlier. So already they're using, implantable devices, able to identify before heart failure symptoms occur. They're able to identify invasively, that filling pressure is rising. That filling pressure is rising and that someone is likely going to have heart failure, and they can use this to actually reduce hospitalization already. Now the big question is, can we do that non-invasively? Can we use this and, track continuously and identify new biomarkers so we can identify these cases even earlier and doing so in a remote fashion? And more than that, we want to use these digital twins to kind of go further and enable forecasting of what would different treatment options, how would they affect this specific patient? What about lifestyle changes? How do we help that specific patient, not on a patient average or on a population average side, but for this patient, if we were to give them this drug, how would that affect them over time? And can we predict that and really inform the physician's choices and allow them to identify the best treatment for that specific patient using these virtual models? So trying to make this a little bit more concrete of, the first step is when I keep talking about a digital twin, giving you a sense of what do I mean by a digital twin? And they're already commonplace in other areas of engineering. So we already have, companies like GE are using digital twins of jet engines all the time. They're informed by streaming sensors, getting, the state of a specific engine. And that's the key here. It's not an idealized engine or a representative engine. It is the state of that specific engine, and it can alert them to engine failures, and when that engine needs to come in to the shop for repair, for example. Our idea here and the goal is, wouldn't it be great if doctors could essentially have a check engine light for the patients and do that for their patients and identify, something is going wrong. Please come in and we'll help identify, we'll help take a proactive approach before something goes wrong. So kind of stepping back, just kind of continue building some of this intuition. We want to look at something just in the short term and see how can a digital twin really help you. We have a lot of guidelines about, aggregate population data about how often and how long someone should run. We kind of know, how much exercise you should be getting. But what about identifying, but what about identifying what is best for that specific patient, for that person that will make a tangible difference for them based on their current status? So, say you want to run for 45 minutes. How do you decide if you want to run for speed or run for endurance? It would be really great if you could have a digital twin who would know your current state, know how much caffeine you've had and how much sleep you've had, where you're at that specific day. Go test out these different options. The digital twin, go try running intervals, a steady state, doing some sprints, and then come back and inform you saying, given how tired you are and where you're at today, you're actually going to get the best bang for your buck if you just do a slow and steady state run today. And that's, kind of what we're trying to see. We're already seeing steps like this in the guidance that you see in, like the resilience feature and advice that you're getting in tools like the Aura app. We're seeing this kind of advice coming into play now, and we want to take it a little bit further, and we want to tie it in and make it a little bit more, tied to the medical side, and have it be a little bit more useful for the clinicians. So we want to be able to identify, let's say, a person who, how do we make someone less susceptible to heart disease over time or cardiovascular disease? How do we look at that long-term plaque buildup that's leading to atherosclerosis? And in the last 20 years, we've gotten really, really good at characterizing vulnerable arterial states. But we've really struggled to kind of convert that into ways to truly, make actionable guidelines that tell us how to reduce, how to reduce and act on these, how to reduce heart disease and act on this information. So what we want are digital twins that are going to capture blood flow over time. That's going to allow us to assess not just if the patient's arteries ever entered this vulnerable state, but if how much time they're actually spending in that vulnerable state and help us identify ways to change it and reduce it. And this is how we're going to start shifting from this reactive care to proactive. We're trying to establish digital twins that are going to capture months or years and move the needle in terms of shifting cardiovascular care. So in order to get to the human digital twin, I'm going to talk about two different examples and kind of just give you two vignettes of what we're talking about in some of our projects. This is just a small sampling of projects that we have going on in our lab, but kind of gives you a sense of how we see digital twins being built, how they can be useful in the clinic, and where some of the open challenges are. So everything I'm talking about today is purely just focused on the vascular digital twin. You can obviously imagine there are many places where digital twins would be applicable in other areas of the body. We're starting with the example of vascular digital twin and kind of using that as our prototype to move forward for other spaces. So if we start with one example looking initially at cardiovascular disease, we'll make sure. Um, so here, this video is going to give you an idea and kind of help, again, like helping you build this intuition. What we're trying to build are really 3D models. So I really want you to have in your head this idea of a physics-based simulation that is capturing that 3D blood flow in a real patient that is informed by their medical imaging, tailored to that patient, understanding how their blood flow is changing based on their activity over time. So we want a 3D representation, we want a virtual model of the patient's vasculature, and then we're going to use physics-based models to mimic blood flow over time. So what you're seeing here is just a representation of a digital twin in a left coronary artery. The amount of time spent with with high forces at different locations, like what you're seeing here, where it's getting, it's very highlighted at the bifurcation. This is showing your velocity. There are other quantities like wall shear stress or pressure or vorticity that are known to be associated with atherosclerosis development. And the amount of time that you're spending in these regions of, say, high wall shear stress or oscillating wall shear stress can indicate the likelihood of disease localization or likely points where you're going to have progression over time. And the key point here, and what you want to capture as you're kind of looking at models like this, it's not just the geometry, it's not just the anatomy that's going to dictate what's happening and where these locations are going to be. It isn't just the heart rate that's going to be predictive of the heart of the disease, but it's really this like synergistic combination of the anatomy, of the flow rates, of how the blood is moving through the body that's going to change on a person by person basis. And that's where we need this patient-specific data, and we need to couple these models with information like information we might get from wearables and sensor data data, from with imaging data, what data we're getting from electronic health records, like, what you might get out of a like a blood screen. So getting your complete blood report of, what is your hematocrit level? Are you anemic? All of these pieces kind of come into play and build a patient-specific simulation. And the way we're going to do that is we use this kind of pipeline where we're starting with the medical images. So at the end of the day, the geometry is one of the biggest driving factors of getting a correct blood flow simulation. So in our work, we're starting with images. Often it's a CT or an MRI, but we also work with 2D angiograms where you can get if you can get the angiograms from different angles, we have ways to reconstruct and create this 3D model. But we need this 3D representation of that patient. We take that imaging data and it's going to go through a process called segmentation. And it's kind of what you're seeing happening in the middle. We go through the Z-stack and essentially are segmenting out and pulling out the 3D geometry of that patient and building that up and creating a 3D mesh file that's representative of that patient's geometry, that patient's anatomy, and allowing that to be the input to the fluid simulation. We have a tool called Harvey that we've been building in my lab for I started it when I was a grad student at Harvard, have continued it at Lawrence Livermore, and now we're working on it at Duke. It's a lattice Boltzmann based code. It's been built from the ground up to work well on large scale supercomputers. And this is really important because these fluid simulations are incredibly computationally intense. And this code, Harvey, takes these 3D mesh files that we get from that segmentation process that you just watched, and then it basically applies a regular Cartesian grid to these mesh files. So every single XYZ coordinate, you're identifying, is it inside the mesh file? Is it an inlet node? Is it a wall node? Is it outside the mesh file? Is it going to be a fluid node? Where are these falling? And then we're just solving fluid dynamics equations at each of these XYZ coordinates. There end up being a lot of XYZ coordinates, which is why it's so computationally intense. But that's kind of, how we're starting to build up these simulations. And then we make it more dynamic. We kind of shift from, just a personalized patient-specific model to getting to, more of what we see is, maybe it's a digital shadow or moving towards a digital twin. When we have this feedback loop that we're getting by connecting it to the wearable data and driving these simulations over long periods of time with this continuous dynamic tracking data we're getting from these wearable sensors. And that's allowing us to start creating these longitudinal hemodynamic maps that are giving you a sense and showing the the blood flow patterns, not just over a single heartbeat, but over, a few days or a few weeks and a few months, and trying to get this long-term view of what's happening to that patient. You can kind of see the pulsation, and we're capturing the real behavior of the blood flow as it moves through, in this case, the coronary arteries, again, driven from data that we're getting from these wearable sensors. So this is all very exciting, but the next step is like, where are we actually at now? How are things going? And, how close is this going to be to translating to the clinic? And that takes us to, if we come back to the center, with this mission of find, track, and treat, this component is really part of that find part. So at this stage, we're really good at building personalized patient-specific models that can be used to diagnose disease non-invasively and incredibly accurately. So one of the key examples that you may be familiar with is looking at cardiovascular disease and helping clinicians try to determine, do they need to place a stent or not? So the patient has chest pain, they go in, the doctor, currently the conventional way of doing this is they're going to assess the narrowing in the coronary arteries. They're going to put an invasive guide wire in the coronary artery. So you see this guide wire going in for the measurement on this side. Where the plaque is, they're going to measure the pressure before the narrowing and the pressure after the narrowing. There's a quantity called fractional flow reserve. There's a quantity called fractional flow reserve that is purely just the pressure gradient between, sorry, my coffee machine is going. It's just the pressure gradient between these 2 points. So it's really just trying to understand what the pressure difference is across that that lesion, across that region of plaque development. And that's what they're going to use to stratify these patients and identify if if those patients, if that FFR is above or below 0.8, is going to determine if they actually have to have a stent placed or not. What I think is What I think is really so we're using this to measure this difference between the patients, and we can do this incredibly accurately. So we can match, we've done a large 200 patient study where we compared the results that we're getting from our non-invasive digital twins to this invasive guide wire, and we're getting incredibly accurate results that are on par with what you're seeing with the guide wire. There are other tools clinically available from companies like HeartFlow and CathWorks that are out there and FDA approved today being used in the clinic to replace these invasive techniques. So we're already seeing it there. We're seeing it in the clinic, and we're kind of at this point where digital twins or these personalized models are starting to replace these invasive techniques. And then what I think is really exciting that's starting to get into is, these digital twins not only allow us to access fractional flow reserve, but they help us access other markers and other information about the blood flow that may be more difficult to measure or you might not be able to get with these invasive techniques. So one of the examples we found is if you're looking at a patient, for instance, who falls in the gray zone. So the region, I'm saying above or below zero point 0.8, you determine if you're going to get the stent. If the gray zone would be right around that zero point 0.8 marker. So let's say the patient is like right on the border, they fall under, they wouldn't be they fall under where they wouldn't be getting a stent. But what if they were right on the borderline and they really should have, and that patient missed that threshold but should have been identified? In the study that we did, what we identified is some of these more complex biomarkers like vorticity can offer more information and more insight about the patients. And it turned out that patients with higher vorticity were more likely to have adverse events down the line, suggesting that maybe, if they're right in that borderline and they're in that gray zone, if you take into account vorticity, we can improve our patient stratification and identify patients that wouldn't have otherwise gotten a stent. But now with this new information and more in-depth data we can get from these models, we can have a more informed decision and identify them and get these patients stents that wouldn't otherwise have gotten it. And that leads us into the next step of trying to track. So now we can find the disease, we can diagnose it, we can treat the patients, but what we want to be able to do is track them as they go about their daily lives and, understand what is your hemodynamic profile as you're running, as you're reading, as you're going to work and, doing everything you would normally do, and see if we can identify problems, as we had said, like before they're going to occur. So we know we can accurately model blood flow in a single time frame. How do we actually move it to longer time periods? And the great part is we're kind of at this huge pivotal shift in healthcare that's driven by the rise of wearables that are continuously capturing dynamic data as people are going about their daily lives. So most people on this call are mostly wearing either an Oura Ring or an Apple Watch or, some kind of wearable, or at a minimum, you're probably carrying your iPhone or other kind of device that's at least capturing your step count as you move around your daily activities. In 2022 alone, there were about 115 million registered Apple Watch users. When you add in data from like Fitbit, from Garmin, from all of the other devices, the scale of information becoming available is really getting to be staggering, and it's really changing how we're able to get data, where we're getting data, and how much we can know about these patients. So we're finally, I think we're kind of moving over to the point where there's a reason to switch from trying to model single heartbeat simulations and capture that single heartbeat. And we're finally at a stage where we have the data to drive these simulations and start asking questions about like, okay, what was your blood flow like over a week or over a month versus just focusing on these short periods? Because traditionally, doctors were collecting this data in a doctor's office. We only have that single time point, that single snapshot. And now we really have access to this continuous stream of health data that's providing much more comprehensive view of patient's health in real time. So with this unprecedented data influx, we're really driving the need for these advanced fluid models to go beyond a single heartbeat. And that's where, we started looking at how do we, where are we at today? How do we move it forward? So the simulation, and I'm kind of replaying this video for a reason. The video that you saw earlier, we made it in 2010. So it was, it is, getting fairly old now. It was actually made with a code called Moofy, the code that even predated Harvey. And it took 6 hours to model one heartbeat. And the key part here is it required the world's biggest supercomputer and the entirety of the world's biggest supercomputer dedicated to the simulation for just, for a full 6 hours. And that's great, and it was a fantastic accomplishment, but not really tractable way to move forward and try to simulate, a week of time. Keep in mind a heartbeat's about, like 0.7 seconds. So if we want to go from that to, let's say, let's capture someone, over their time for a year, over the time even for, several days, it's really going to be intractable. Even if we just sit around and wait for, if we move on today's supercomputers and take this simulation and try to go run it on Frontier, one of the biggest supercomputers in the world today, we wouldn't be able to, that wouldn't be enough, and we wouldn't be able to do that. And honestly, trying to ask for Frontier for, all of Frontier dedicated to us for the next 3 or 4 months to just start running these simulations is also probably pretty impractical. So for digital twins to be really useful, we want to be able to move beyond a single heartbeat, which is what, our field has really spent the last, 20 years trying to get to the point of just getting high fidelity single heartbeat simulations. We want to be able to move beyond a single heartbeat, and we want it to be able to be fast enough to actually provide real insights. So, the example we keep using in our lab is thinking about hurricanes. So, if we have these simulations and, you're watching on the weather and you're trying to understand what's happening with a hurricane, where is it going to hit landfall? When is it going to hit landfall? The key piece here is if, you are trying to figure out what's happening for you today, and it takes a simulation of the hurricane 2 weeks to run to tell you that it's going to hit landfall tomorrow, that's not helpful. And in the same way, it's really not helpful to have a really high fidelity, robust simulation that's going to tell you, 3 weeks from now, you're going to have a heart attack, but it takes me 2 years to run the simulation. Great to have an accurate computational model, less helpful in actually being active and having an impact on someone's life. So we're trying to really address these issues. Um, so I'll move into how we actually do it. I know I'm trying to keep an eye on time here. So one of the methods we've really introduced is we're referring to it as developing these longitudinal hemodynamic maps. So, fortunately, as I'm trying to work on these simulations, when we first started working on this, I think it was, like maybe a year and a half, 2 years ago, no one had ever published more than 30 heartbeats. So we're kind of limited. There've been like decades of work really getting to the stage of how do we get these accurate models. And then I came to my team and was like, it's great that we can do all of this, but we want to move from 30 heartbeats to let's try it for weeks, let's try it for months, or can we do more like years? And luckily, we have really great people on the team like Cyrus who are willing to try to kind of hit this challenge head on and figure out ways to really tackle this problem. So not only did he help find a way to drive these simulations from wearable data, but also extended this, we created this parallel in time approach that really extended the simulation domain and the amount of time that could be modeled. So this longitudinal hemodynamic mapping framework is allowing us to jump from 30 heartbeats to much longer time periods. So to test this, we started off with his model. We started, just dedicating a large portion of the Duke Compute cluster that belonged to our lab, shut it down for a few months, and just ran a really long simulation and got, the ground truth simulation for 750 heartbeats with a full 3D blood flow to see, if we drove this from a wearable device, what is that ground truth of the 3D blood flow for the simulation? And are there ways to get at that in a much more computationally, tractable manner? So what you're seeing here is using this longitudinal hemodynamic mapping, and I apologize for not being able to go into the detail of this, in the length of this talk of how this model is set up. Definitely happy to answer questions at the end if people want to hear more about how we're setting this up, or come to the coffee hour and talk about it more in detail. But basically, we're kind of using, essentially it's a parallel in time approach. We're breaking it down in chunks and trying to figure out different blocks that we can fit back together. So if if the activity that you're doing at 10 a.m. on Monday isn't very different from what you did on 10 a.m. on Tuesday, we can kind of simulate it once and plug these blocks back in and have it take this parallel in time approach to really reconstructing someone's blood flow over a long period of time. The nice piece here is we were actually able to show, as you see, it's a little bit hard to see, I think, on the screen. But if you look in this part, the black line is showing what we got from that explicit simulation, meaning when we shut down the cluster, we ran it explicitly, and we just did a brute force of run a simulation for several months and get the flow results. That's what you're seeing in the black line. And then we use the LHMF approach, which is incredibly more computationally tractable. We get like a very similar result within about 1% accuracy for, you can see here we have velocity, we're looking at wall shear stress, the different blood flow quantities that we really care about over time. So this study is really getting to, like, showing these results and just highlighting how impactful LHMF has been in accelerating these long-term cardiovascular simulations. So once Cyrus was able to complete the 750 simulation, which again was, much larger than anyone had ever modeled with 3D flow before, he then kind of pushed it and moved on to try capturing actually like 6 weeks of activity. So what you're seeing here, you can kind of see it's a little flickering a little bit here. You're watching the wall shear stress, which is a key quantity associated with atherosclerosis development. So we know that, when the vessels are in read of areas of, less than maybe 2 Pascal or 1 Pascal of wall shear stress, they're more likely to have disease localize or progress in those regions. So the question is, based on someone's activity, how much time are they spending in these at-risk regions? And previously, the way we would get at this is having a representative heartbeat that might be for an exercise state, a representative resting state, or looking at, representative specific heartbeats and kind of averaging over time. And this is really the first time we were able to capture 3D flow over 6 weeks of time and see how the wall shear stress was going to change. And what ended up happening is it showed that using these these longitudinal hemodynamic maps, you get a different view and a more robust view of what's really happening for that patient. So if you just looked at that representative resting heartbeat or a representative exercise heartbeat, you're not really getting the whole picture. Whereas if you had this, the LHM, which is capturing, what's happening over the course of 6 weeks, you really get a statistically different view of that patient's blood flow, understanding how much time in each specific region in a spatial way is being spent in these at-risk zones. So it's really helping us identify what part of the vessels are being, how much time different parts of the vessels are spending in these regions, where they are, and what might be influencing them. So it's a different way to really like, identify these statistical differences. So with that, we're really trying to set this approach up to really, for the first time, capture these personalized cardiovascular blood flow models that are capturing this real world activity over extended periods. So this level of detail is setting the stage for these next major advances in the development of cardiovascular digital twins. We see this as, taking that first critical step to getting to these digital models that have the potential to really transform the care by providing this ongoing dynamic picture of cardiovascular health that's going to allow us to predict these risks, tailor the interventions, and really optimize treatments. So some of the ways we're looking at this is, the first step with the computational advancements, we're able to, combine with wearable technology and really capture these patients over time in a remote fashion. So it's allowing us for the first time to really start tracking their 3D blood flow and have a sense of how that's changing as they go about their daily lives. So we're starting to collaborate with doctors in a variety of disciplines to capture real patients' data as they're engaging in these activities. So we're working on different diseases, which again, I can't, in the span of this talk, go into all of them, but hopefully over the next year, if you attend some of our other seminars, you might be able to hear more information about, we have ongoing work with vascular surgeons in, the carotid vascular space. We're looking at heart failure, we're looking at coronary disease. We're looking at a wide array of areas where these long-term maps can really start playing a bigger difference. And then we're not just trying to track these patients. We want to use these models to prospectively treat the patients and improve the treatment options. So we're trying to use these digital twins to allow the doctor, before they ever step foot in the operating room, they can test out either, different scenarios of saying, if this patient starts exercising or this patient has a different, starts having different lifestyle choices, how could that affect the patient over time? So you have this option of, really informing for that specific patient what would happen with different hypothetical paths. So beyond this real-time monitoring, what happens, if you were to place a stent, see how different stent options would work, how different stent options combined with different lifestyle choices would work for that patient. And that way, before the doctor ever enters that room, they can test out and say, what is the best stent or what is the best treatment option for that specific patient? And we can use these prospective models to then guide that treatment and inform, giving advice to both the clinician and the patient themselves of what are better ways to act for that specific patient, and really shift the way we're looking at how these patients are being treated. One specific way that we've been developing in the lab is a combination of this virtual reality tool we have called Harviz, and then a new way of interacting with it that we're calling Harvi for virtual interaction. And it's kind of bringing in this machine learning approach to taking the initial geometry that we're getting from the scans. So you have the medical images before treatment, and then you can kind of see here where we're trying, and I'll pause it here, trying out different treatment options. So again, before the doctor goes into the operating room, they can virtually try placing different stents. They can try, in this case, we're looking at a bifurcation model. So in that case, you have a lesion right here. I'll put it up here. Yeah, you have a lesion right here. So you have one lesion here and one lesion over here. And there's open questions of how do you determine, do you need to treat both lesions? Should you treat one lesion? And obviously it's not possible to go treat one lesion before they go into the operating room and, see what's going to happen with that patient. You really want them to go in and say like, okay, I'm going to treat both lesions. I should treat, the one in the main branch, or I should treat the one in the side branch, and have a game plan before they go into the operating room and know what they need to do. They can do that now virtually using these digital twins, and we can try out different options and different treatment options virtually, and I'll let it start playing again to see how that's going to affect the patient, how that's going to change the geometry, and do all of this again like beforehand in real-time planning. So the exciting part here is being able to modify this geometry and try different options. So you're kind of seeing how easy it is for the doctors to interact. This tool will can also be used in a virtual reality environment for more immersive interactive options. And then the cool part was where like Cyrus connected this with Harvi, and created Harvi with the machine learning side of it's really giving real-time feedback and real-time interaction. So by tying it in with the AI, he was able to reduce this the lead time for a new patient and give real-time prediction of what the flow would be. So currently, when you're doing interacting with kind of virtual treatment plans like this, most of the tools require something like 24 to 48 hours of training time for that specific patient. So the patient comes in, you have your imaging, you get your data. The AI model trains on that patient for 24 to 48 hours. And then after that, the doctor can have real-time interaction. But that 24 to 48 hours means that the patient has left the office, a lot, it's kind of delaying when they can have that interaction. And by introducing Harvi and different methods, Cyrus is able to reduce that down to about a 10-minute training time so that we can train on a specific patient in about 10 minutes and then get immediate results, seeing, if I were here, we have like different lesions up here, and we're trying treatment 1 where we're treating lesion A, trying treatment 2 where we're treating lesion B, and trying to see how that's going to affect the results. And what you're seeing on the left here is the machine learning based Harvi inspired prediction of the flow. And then on the right is like the result of the actual fluid simulator. So we're seeing a strong correlation and getting highly accurate results from the machine learning approaches. The other exciting part with this and go through is that we have this implemented, and we have this kind of interacting with the Harviz tool, which is really this virtual reality based immersive option. So the one on the top right is just kind of seeing the body floating using the Vision Pro, but it can give you a sense of how we can create this intuitive interactive model so the doctor can go in and see that see the simulated digital twin, rotate it around, really interact with it. And then if you look here, they can, work in 3D space. This is a Z space where you just wear the goggles instead of a head-mounted display, and they're able to really see and interact with that data. So I'm going to shift gears a little bit. I know I have about like 15 minutes left or so, and I want to try to leave some time for questions. I wanted to just give a little bit of an example and talk a little bit about what we're doing in the cancer space. And everything I've talked to up to this point is really trying to make translatable tools that are much closer to the clinic. On the cancer side, we're really trying to understand, it's more of a basic science approach of like, what is it about the cancer cells that are making them more metastatic? How do we inform treatment options on that side? And I put Jerry Lee's picture here. He's a professor now at USC, but I think it's also just kind of an important, identifying how things happen and how things kind of come about as we go through. So The talk that you just saw in the video that I just I've been showing kind of repeatedly about the coronary arteries from 2010. The first time I showed that video was in 2010, 2009 timeframe. So maybe it was back at that stage. Um, at the supercomputing conference as part of like a talk I was giving in grad school. So it was very much, this is where we're at with cardiovascular disease. This is what we're trying to build. And Jerry Lee attended that talk, and his background was in cancer. And he saw the talk and was like, this is all great. I'm glad you guys are working on heart disease, and that's fantastic. But what if we actually put a cancer cell in the simulation? What could we learn about how, a cancer cell coming off of a primary tumor moving through the body, could you use these models to really understand why that cancer cell is going to different locations, what it is about that cancer cell that's making it metastatic, and really like, how do we take the models that have really been developed and refined for cardiovascular disease and apply it to something very different in the cancer space. So kind of definitely like the random talk of him, the random chance of him attending the talk at supercomputing has really had a huge impact on the direction of our research in the lab, and kind of where Randall's lab is really set up. So we currently, I think it's maybe split in half of like a lot of people are working on the bulk fluid vascular disease side, and then a lot of people are really focused on this fluid structure interaction side of what do we understand about the cancer cells, and a lot of that really did come from this random interaction with Jerry. So I think it's worth pointing out of the talks, the comments you get at the end of talks can have big impacts. With that, I'll go into a little bit of what we're doing. I'm kind of do a flyby, quick view of what we're doing on cancer cells and what we're trying to develop on the cellular mechanics side, just to give you a sense of the different ways we're using digital twins and computational models. So again, this is coming from like first principles physics-based modeling, trying to create a really high fidelity model of what the cancer cell and all the associated red blood cells are doing. So the goal here is to create high fidelity models of deformable red blood cells, cancer cells, and couple that with the fluid in a complex geometry and really understand what's happening. So we're using the lattice-Boltzmann fluid component that we had in the first part of the talk, and we've introduced a finite element model for the different cells, and they're coupling in with immerse boundary to kind of connect between the cells and the fluid side of things. So we're bridging all of these scales, but the first part we need to start with, when we first started, you want to kind of start small before you get to, let's try to get to a large scale fluid structure interaction model. The first question we had is, can we model a red blood cell accurately, and can we model a cancer cell accurately? And that was, if we can model one cell and prove that we can model the one cell correctly, then we can start scaling up and capturing much larger dynamics and interactions between the cells. So Mariana, led a lot of the work to validate our red blood cell model, where she compared the results of our simulation for one single red blood cell to different experiments like micropipette aspiration, the results from optical tweezers. And that's kind of what you're seeing at the top here, is just really ensuring that we're capturing those red blood cell dynamics correctly. Peter Blogue was, who's now a faculty over at New Jersey Institute of Technology, was a postdoc in the lab who helped us, take our cell model and tune it to specific cancer cells. So it's important to be able to, actually model which cancer cell you want to capture. So whether it's going to be a lung cancer cell or a TMET or a breast cancer cell, we want to be able to tune the computational simulation and figure out what is the minimal, least computationally heavy way of accurately capturing the behavior that we want in these computational tools. So how do we actually capture the behavior we need and what we care about, and what can we throw away so that the computational model can actually be tractable and move forward? So what he developed was a way. We worked with Scott Manalis's team up at MIT. They were running their experiments in the SRM device at the time. That's kind of what you're seeing here. So we have this device where there's a constriction and the cancer cell is moving through that constriction. And what we really care about is that passage time. So Scott's team was able to measure this passage time for a range of different cell types. And that's what you're seeing here. Blue was the TMET. Orange is a cell line called L1210. And what you're seeing on the y-axis is that passage time, and then the radius of the different cells and like that range is going along the x-axis. And what Peter was able to do was really create a way of matching and tuning the shear modulus and the characteristics and the nucleus size and information about the cancer cell to match to match those specific cell lines and actually replicate that experimental data. So just validating the model and making sure both our cells are accurate and able to capture what we want was a key first step. And I'll start jumping through this a little bit quicker so you can see. Um, and then once we had a real model, what we wanted to do is then understand something about cancer. So we started working with Monica Moya's lab at Lawrence Livermore National Lab, and Rick Hines did a fantastic job where they bioprint these endothelialized channels. They're able to put cancer cells in the endothelialized channels and see where the cancer cells are actually going to adhere to. So it gave us, a real device to start studying cancer cell adhesion and trying to understand what it was about the flow properties, the environment, that microenvironment, the cancer cells itself that are causing them to adhere in different locations. So what you're seeing here is the experimental results showing different spots of where they were adhering. And what's kind of fun is like this looks like a simple channel and it's just a basic double bifurcation. When they do the endothelialized bioprinting, it didn't come out, as accurate. It's not the perfect bifurcation channel that you would want, but that actually ended up being really useful and interesting. Like the impurities and imperfections from the bioprinting made slight differences. Like you can kind of see it here where it's like this bifurcation has a bit of an angle and it's a little bit tighter, then this one's a little bit wider. But those differences ended up resulting in changes in flow patterns. And when we saw the location of where the cancer cells were adhering, it was at different points in these geometries. So there was more adherence here than you saw in the bifurcation up at the top. So then we were able to couple it with a computational simulation. In this case, we were just modeling flow simulations to see what was it about the microenvironment that may have been different to start just trying to understand why are the cancer cells adhering down here versus up there. In an ideal world, we really wanted to be able to model this entire 18 mm device with all of the cells moving through at the resolution where you could capture, the cellular adhesion with individual ligand and receptors. And we weren't able to do that at that time, even with the world's biggest supercomputers. So we are kind of limited to looking at the fluid properties. It was still really interesting in that, we saw differences in wall shear stress where we had more like areas of increased attachment, but we were kind of limited in the studies that we could do. We coupled this with, some idealized geometries, kind of mimicking like cell movement in similar bifurcations. You can see it's a very like small portion of that region, but it helped us really understand that, the mechanical properties of the cells did strongly influence the residence time. So it helped us start being able to probe, was it the fluid component? Is it the microenvironment? Is it the cellular interaction? What's the synergy between the two? And how do we start answering these questions of why these cells are adhering in different locations? We were able to move on from there, and Daniel added in the first adhesive model. And what's cool about this is you kind of watch through, you can see the little, like the kind of like little cylinders. Those are individual ligand receptor pairings, capturing that adhesive property between the cancer cell and this idealized geometry. What I want you to get out of this is just seeing that, if you put the cancer cell here, if you don't have adhesion, which is what we have at the top, it's going to take a different trajectory than if you take into account adhesion. So the lesson learned here is like adhesion is very important, and you can actually, significantly alter cell trajectory by taking into account adhesion or not. So we want to be able to work towards a model that, in an ideal world would take this entire 18 mm geometry, but at a resolution where we could capture adhesion. Um, Daniel then was able to parallelize and kind of make use of these large-scale GPU-based supercomputers and was able to parallelize the model so you could model multiple cells in a realistic geometry and get a much more complex, jumping from this idealized geometry that we had in about 2022, just later in 2022 with all the parallelization. And he was, a fantastic programmer that was able to put this together. He was able to jump it to be able to get to this much more complex geometry. But the thing you're going to notice here is we're still a long way away from this 18 mm goal, just for getting that idealized bioprinted double bifurcation geometry. Just to kind of get a zoomed in view of like, this is what the model looked like. This is in 2022. We're able to model multiple cells. We can capture that, like you can kind of see the dots on each, or like the the pattern of the ligands on the cell itself. As it gets close, you'll see different pieces of like, different points where it starts to adhere and stick to different regions in that area. So we're getting, we're kind of building the complexity of these models, but we're still a little bit of ways from where we want to be. So then as we started asking, how do we get to the point where we could model 18 millimeters? Or, let's think even bigger. Wouldn't it be great to model across the centimeters or across the meter scale? We really wanted to be able to capture cell-cell interaction at these longer distances. Um, I'll kind of start going a little bit quicker, but the key part here, this little tiny cylinder that's about 3.1 millimeters tall, it holds about 550 million red blood cells with normal hematocrit levels for human red blood cells. It took the entirety of the world's biggest supercomputer in 2022. We were on Summit at Oak Ridge National Lab. If we had the entire system, we could model that teeny tiny 3.1 millimeter region and get 550 million red blood cells, which is great and a huge, it's 550 million red blood cells is a huge amount to be simulating and really exciting, but it's still just this teeny tiny 3.1 millimeters. And again, just waiting for the next big supercomputer. If we just waited for Aurora or waited for Frontier, we might be able to get to like, a 5 millimeter or 6 millimeter region. We're not getting to the point where we can actually capture regions over like, many millimeters, centimeters. The grand challenge would be coming to meters. So we realized we needed to do something different. We couldn't just take a brute force approach. And that's where we started looking at these adaptive refinement models. So what we introduced is called the adaptive physics refinement model. Colloquial in the lab, we call it the moving window model. Essentially, we put a moving window around the cell of interest. Inside the window, you have all of those cell-cell interactions. You have all the red blood cells in that moving window. You're capturing the key cellular components, but away from the window, we just have bulk fluid. So we're basing it on the fact and the idea that, the orientation of the red blood cell that the cancer cell is bumping into matters near the red blood cell. 5 centimeters away, if the red blood cell is, to the left, to the right, our hypothesis is not going to affect the geometry, or affect the trajectory. But you still need to take into account the impact of the geometry on the fluid itself. So by capturing the bulk fluid behavior in the longer distances, but the high fidelity cell resolution in the near distances, our hypothesis was you would be able to actually capture the accurate trajectory. So kind of giving you a better view of this, and I'll start skipping through. This is just an animation of the idea. Like we have this high resolution bulk window following the trajectory of the cancer cell. The cells move along with it, but then you're capturing that overall bulk fluid in the overall domain. The key piece was this actually was how we were able to get to modeling the flow in that 18 millimeter channel. And it allowed us to have this high resolution window around the cancer cell, which drastically cut down the computational component. The EFSI, which is the explicit brute force model, required 22 terabytes. Our adaptive physics refinement model only took about 216 gigabytes. So by doing this, we're drastically reducing the computational requirements and making this more doable. I'll skip through here, but this is a key part of I like to point this one out with the expanded channel. This is just validating that it actually works. So if you're going to talk about these models, you have to show some of these simulations. The part I want you to notice is in the expanded channel, the presence of the expansion causes the cancer cell to marginate to the edges. If you were just modeling the box doesn't see the expanded channel. So if you were just modeling the window and you didn't have a properly coupled model in place, you wouldn't know that you were at the expansion. You wouldn't have that margination occur. But by having a properly coupled model, we're able to actually capture the proper trajectory of that cancer cell and match what we're getting in a brute force model versus what we're getting with the adaptive physics refinement approach, which allows us to get accurate trajectories, capture the cellular domain, but over much longer distances than we were ever able to do before. So here's where we're showing an example in a cerebral vasculature. It only took about 9 to 6 node hours to get from this position all the way over here. So we're getting much longer trajectories with cell-cell interaction than what we had been able to do. kind of move through here. And now this is the work that Aristotle had shown at BMES earlier. He's even added adhesion into this window. So he showed this in October. We can now go to much larger regions, and we can actually get to the point where we have adhesion in these models. We can start answering some interesting questions about cancer cell mechanics and how that influences where they're adhering, why they're adhering there, and really start addressing these questions that have been outstanding. So with that, I want to leave a couple seconds for questions. So I'll kind of wrap up and say that, we're kind of focusing on vascular digital twins, but obviously the digital twin technology is going to extend way beyond just vascular models. We've really focused on how to extend the time domain of the simulations as well as the spatial domain of the simulations. But we're really excited through the center to see how we can advance the tie-in with the virtual reality side, the tie-in with more wearable sensors and more advanced sensors on that end. We're tying in more, AI training on top of all this and creating these AI surrogates to reduce computational component complexity even further, and trying to expand into other disease areas like neuro, in neuro or in other spaces. So with that, I'll kind of end there and say, acknowledge the whole team. And obviously, none of this would be possible without the rest of the team and all the hard work everybody's been doing in the lab, over the last decade of the lab's existence, and all of our key collaborators. And I'll stick this up so you have it while we ask questions of please stay tuned with us on what's going on with the center. Use this QR code here to join our email list. We'd love to have you guys be involved. We have a lot of really exciting talks coming up over the next semester. So we have Ashley Ford-Versipt from Buffalo is going to be giving one of the next talks. She is absolutely a fantastic modeler and definitely worth coming to that talk. So I'll pause there and see if anyone has any questions for me as we kind of wrap up before the coffee hour.